Hello everyone, I'm Dr. Gayatri Veeramani Jayaraman. I completed my nephrology fellowship training at Harvard Medical School in the joint program with the Brigham and Women's Hospital and Massachusetts General Hospital. I'm a US board certified physician. I'm here to just talk about some interesting nutraceutical approaches in treating kidney disease. Let's just spend a couple of minutes and talk about renal physiology. We know that the kidney gets about 20 to 25% of the cardiac output. Interestingly, a lot of this is actually directed to the renal cortex, and the renal medulla is prone to hypoxia and low perfusion. There have been multiple studies on this, and in checking the partial pressure of oxygen in the renal medulla and the renal cortex, the renal medulla is always noted to have lower concentration of oxygen compared to the cortex. We also know that the kidney is very sensitive to hypoxia-induced damage, and we've seen a lot of this clinically in cases of profound hypotension and other etiology. Hypoxia can actually lead to increased oxidative stress, and this happens through various mechanisms, including oxygen-dependent enzymes like NADPH oxidase, cytochrome C oxidase, and other mechanisms. And oxidative stress is increased in renal hypoxia. In fact, oxidative stress and chronic hypoxia also has a role in progression of AKI to CKD. We know that a certain percent of AKI survivors can develop CKD in the future, and it's interesting, and more data is coming out on hypoxia and reactive oxygen species and oxidative stress and its role in renal pathology. Just keeping that in mind, the role of antioxidants and ROS scavengers become very important in protecting kidney function. Just looking at some of the nutraceuticals that are available in India, there are combinations of N-Acetylcysteine and taurine. There's a combination of N-Acetylcysteine and Pyridoxamine. There are alpha ketoanalogs and the sodium bicarbonate. And today, let's talk about all four of them. There's a lot of data on N-Acetylcysteine. N-Acetylcysteine is actually considered to be one of the most powerful antioxidants available, and the use of N-Acetylcysteine is plenty. And there's a lot of data in kidney disease as well. There was actually a large study of about 125,000 CKD patients that were followed over 10 years, and NAC use was actually associated with 18% risk reduction for ESRD. N-Acetylcysteine is also a very important precursor of glutathione. Taurine actually works as an osmoregulator and has a protective role in diabetic nephropathy, and has a protective role in type 1 diabetes, type 2 diabetes, and renal protective effects through its anti-inflammatory, osmoregulatory properties, and antioxidant properties, and there's a lot of data available for this. There was actually a study that was done in 2008 by Dr. Vijay Vishwanathan in a WHO-affiliated center, which showed taurine in combination with N-Acetylcysteine was useful in reducing microalbuminuria by up to 50%, and a reduction in TGF-beta levels was also seen. N-Acetylcysteine and taurine basically prevent ROS-mediated damage to the glomerular filtration barrier and help preserve the glomerular filtration barrier, thereby reducing microalbuminuria. And with respect to pyridoxamine, there's a lot of data available on this, and growing interest in role of advanced glycation end products, which are basically hyperglycemia-induced glycated lipids and proteins that can have a damaging role. And these AGEs and advanced glycation end products have been implicated in diabetes complications, including diabetic nephropathy, diabetic retinopathy, and these AGEs also lead to increased oxidative stress and ROS production. Vice versa, increased oxidative stress can also, that's seen in CKD and seen in diabetes, can also lead to increased formation of AGEs. And pyridoxamine can inhibit formation of these AGEs and is an active form of vitamin B6 and possibly has a role in inhibiting AGE formation, and there's increasing data available on this. There was also a trial in CKD, and pyridoxamine was studied in the US, and 27% reduction in creatinine was seen in the CKD patient over 6 months. There was also a recent Indian study by a renowned nephrologist on a combination of N-Acetylcysteine and pyridoxamine. 72 CKD patients were studied, and a combination of N-Acetylcysteine and pyridoxamine was noted to increase eGFR by about 8.15 units in 6 months' time. And as nephrologists, diabetologists, and physicians, we know that in CKD and diabetic nephropathy and non-diabetic CKD as well, just preserving the residual kidney function, is a job well done, and GFR maintenance is a job well done. And this combination was actually noted to increase eGFR by 8.15 units in 6 months' time. And in patients with normal bicarbonate levels, which means no metabolic acidosis, NAC and pyridoxamine was noted to increase eGFR by 10.16 units in 6 months' time.